Again, hello everyone. Thank you for joining us today. My name is Greg Conko. I'm a senior fellow at the Competitive Enterprise Institute, and I'll be the host of today's discussion on the regulation of diagnostic testing. Now, we hear daily updates on the status of COVID-19, and for many of us, the regular check-ins on the number of tests being performed and the number of positive results are among the key data points in assessing our progress and determining how quickly we'll be able to get back to normal. In fact, if we ever really can get back to normal. So it's hard to believe sometimes that just 5 months ago, practically no one in the United States had been tested. At the end of February, a full month after the first COVID diagnosis, and while the disease started to run rampant, American public health officials had tested fewer than 500 people total. Now, that delay put us on a back foot that continues to affect us today. We'll discuss a bit about why that happened and what we can do to prevent it from happening again. We'll also discuss where we are now with testing, what role it may need to play going forward as we debate how best to reopen businesses, schools, social gatherings, and the myriad other routines and behaviors of everyday life. We'll have about 45 minutes of discussion on the topic and then take questions from you in the audience. If you'd like, please feel free to submit a question at any time using the Q&A box at the bottom of your screen or by emailing questions to events@cei.org. Now, we have a couple of great speakers with us today. First up, Roger Klein is a faculty fellow at the Center for Law, Science, and Innovation at Arizona State University's Sandra Day O'Connor College of Law. That's a mouthful. He's also Chief Medical Officer of Omniseek. He's both a lawyer and a doctor who previously worked at several health institutions, including as Director of Molecular Pathology at the Cleveland Clinic. He's a former advisor to a number of federal health agencies, and he served in several leadership positions with the Association of Molecular Pathology, a scientific society for professionals in the field of molecular diagnostics, where he's been actively involved in debates over the regulation of diagnostic testing for a number of years. Like Roger, Joel Zinberg is both a lawyer and a medical doctor. He is now a senior fellow at the Competitive Enterprise Institute and also an associate clinical professor of surgery at Mount Sinai Hospital's Icahn School of Medicine. Joel has practiced general and oncologic surgery in New York for nearly 30 years. He's taught at Columbia University Law School, and from 2017 to 2019, he served as general counsel and senior economist at the White House Council on Economic Advisors. Now, a little while ago, Joel reminded me that he and Roger both went to Yale Law School, just a few years apart, but to different medical schools. And it occurred to me that my mother was proud of me just for going to law school. I imagine the bragging rights of a parent whose kid is both a doctor and a lawyer. And gentlemen, thank you both for joining us. So Joel, let me start with you. How did we get off to such a slow start with the COVID testing?
Well, good morning, Greg. Good morning, everybody. And Greg, I do hope your mother gets over the disappointment you didn't attend medical school as well. Right. In brief, the reason we got such a slow start with COVID-19 diagnostic testing was because of overregulation, incompetence, and unnecessary delays by HHS, by the FDA, and by CDC. They managed to stifle the development of and availability of tests for the new coronavirus that causes COVID-19 for the entire month of February. And they insisted that during that month, American laboratories use a faulty test that the CDC had created. So let me sketch out a little bit of chronology here, so give people the background. So we do know that the Chinese knew about the new coronavirus and the new disease in November, possibly even October, but the rest of the world did not know until late December. By mid-January, the identity and the genetic sequence of the virus was known, it was public, and developers around the world began trying to make up tests. And So for example, in Germany, a German infectious disease research institute published methods to create a new test, and a German company had a new test within a matter of days. World Health Organization picked up that test, began shipping it around the world. So by early February, they'd shipped about 250,000 tests. By the end of the month, they had shipped about 1.5 million tests. The British, the Spanish, the Koreans, they all had companies that were developing tests. But in this country, where we had a number of laboratories and companies who were anxious to develop tests, and some of them actually went ahead and developed tests, they were held back and not allowed to use those tests by our complex regulatory scheme that effectively creates two broad categories of diagnostic tests that can be approved and used. So you have the Medical Device Amendments of 1976, which amended the Food, Drug, and Cosmetic Act, and it gives the FDA authority to regulate medical devices, which includes diagnostic tests. And you have a second statute, which is the Clinical Laboratory Amendments Act of 1988, which is known as CLIA, and that gives the CMS the authority to regulate clinical labs doing human testing. And that includes what are called laboratory developed tests, or LDTs, which are tests that are created, manufactured, and used within a single laboratory. And CLIA designates and certifies different levels of complexity for testing. Whoops, excuse me 1 second here. It also,
Call from Go.
excuse me 1 second.
NG.
I'm sorry about that. It also, I thought I had disconnected that. It also, it gives states the authority to create their own standards, and if they're more comprehensive or stricter than the CMS standards, then they can, CLIA allows them to go ahead. Now, the FDA has always claimed that it had the authority to regulate all the tests, including LDTs, but as a matter of course, over the last several decades, it never regulated the LDTs. It always exercised what they called enforcement discretion and allowed those tests to go forward without FDA approval. So the de facto regulatory scheme was this. You had, for tests that were going to be broadly distributed and commercially developed, FDA required pre-market approval or clearance. For the LDTs, no FDA approval was required. So here you had a situation where in the beginning of this emerging infectious disease outbreak, the worst pandemic in 100 years, FDA suddenly decided that they were going to forego enforcement discretion. They're not going to look the other way. They're going to require FDA approval. And they acknowledge the need for increasing testing capacity, but they paradoxically claim this is a serious disease. A lot of people could get sick, people could die. They need to follow it from a public health perspective. Therefore, they're going to make it harder to get on the market and perform testing. They're going to require FDA approval. And then FDA compounded the problem when at the end of January, when Secretary Azar declared a public health emergency and the emergency use authorization declaration that enables the FDA to issue what are called emergency use authorizations, or EUAs. Those EUAs could have been used to rapidly approve drugs because EUA only require that they show that the medical product may be effective, which is a much lower standard than the typical FDA approval process. But in fact, for the entire month of February, the FDA would not issue any EUAs except for an EUA for the CDC developed test for the new virus. And that test, when it shipped on February the 5th, was rapidly found to be defective. CDC acknowledged that within a few days, but insisted on trying to correct the test itself. It wouldn't allow other tests to go forward. Even when laboratories told CDC, we know what's wrong with the test, we know how to fix it, CDC insisted. And the upshot was that by the end of February, we had performed about 4,000 tests, whereas the rest of the world had been performing hundreds of thousands of tests. So at the end of the day, we ended up with a very defective testing scheme because of this regulatory structure, and it wasn't remedied until the end of February when the FDA at long last issued guidance for the EUA process, and they updated that and made it a little better. So the upshot is that the FDA made it harder for LDTs to be utilized. They now had to apply for and get an EUA. And they made it easier for the commercial manufacturers to broadly distribute tests because they didn't have to go through approval. But all of that only happened after a month's delay.
So Roger, this clampdown by FDA on lab-developed tests, it came out of nowhere, but it wasn't really new. It was actually in the works for quite some time. Tell us a little bit about your experience with that.
So this has been a long-running debate, and the medical device amendments were passed in 1976, as Joel suggested, but it took until 1992 for FDA to officially, or for the first time that we're aware of publicly, announced that they had authority over laboratory developed tests. And there had been a running debate with the laboratory community. Through the years, FDA had taken a number of steps toward trying to regulate laboratory developed tests. There was always pushback. They were going to do it during I think 2012, and when the Congress changed, FDA backed off on it. And FDA actually proposed a draft guidance that was going to be used for regulation of laboratory developed tests in toto. I mean, they had a broad scheme that they published that would regulate the entire field. And after the election in 2016, they withdrew it. Maybe a week or two after the election, and decided not to go forward. But I think they've incrementally taken individual steps. For example, 23andMe, which is not a conventional laboratory but was selling direct-to-consumer tests, was required to submit its tests to the FDA. 23andMe is actually a sales vendor and report generator, but its tests are performed at a large commercial laboratory. During the Zika epidemic in 2016, in March, FDA issued warning letters to Methodist Hospital and to I guess it was Baylor, but requiring them to, or at least questioning them and asking them to discuss submission of approval, despite the lack, actually, I think, of an emergency use authorization. So no formal no formal federal emergency had been declared, but they went ahead. FDA went ahead anyway and requested these laboratories that were setting up tests as they normally do. I mean, there's 13 billion tests in the United States. Most are performed in clinical laboratories, private labs, either commercial or hospital, or other private sector labs that aren't regulated by FDA. But anyway, so in March of 2016, they set a precedent, and they followed that precedent in this particular case, imposing regulations that didn't previously exist on most laboratories. University of Washington had a test ready to go. They had validated it, and Washington State was where the first community spread, the first case of community spread was identified, but University of Washington couldn't use their tests. And as people probably remember, there was an outbreak in the Kirkland nursing home. I think ultimately maybe 40 or 50 people died from that. But University of Washington wasn't able to test. There were other labs around the country that were ready to test and weren't able to do so. So as Joel chronicled, FDA really stood in the way of our detection of the epidemic sooner by vesting the sole authority to test in CDC, and which was supposed to distribute its tests to to public health laboratories, which, as Joel suggested, were unable to validate it because there was contamination in what's called the negative control.
So you and Joel both drew a distinction between laboratory developed tests and other commercially available tests. Could you tell us a little bit more about what distinguishes them and how they're regulated? And, you know, is the Food and Drug Administration regulation of commercial tests any better?
So I mean, I can speak to that. I've spent a lot of time on it. So the problem is we have laboratory tests that are commercially manufactured and distributed and sold to labs throughout the country. Those tests are regulated by FDA under the medical device amendments. Now, the regulations that are set up under the medical device amendments are well suited for implantable devices like stents or hips, but they don't fit laboratory tests particularly well. And what's ended up happening is that we've made it burdensome for laboratory test vendors to sell tests that they've manufactured. It's been a costly process, a slow process, and a difficult to modify process. And what's happened in many instances is by the time the tests come out, they're outdated. And that's created a dynamic in which laboratory developed tests have largely filled holes. And then people have continued to use them because they're considerably less expensive than manufacturers end up having to charge. This is in contrast to Europe, for example, where they haven't historically had an FDA that pre-approves tests. They've had a process called CE marking, where the laboratory or where the manufacturers attest to using what are called good manufacturing processes. But they haven't had an expensive FDA approval in Europe. People have just released the tests. I think one of the problems, and then I'll stop, but one of the problems has been FDA has had an onerous clinical requirement that exceeds its value, in my view, in many instances in its clearances or its approvals of tests. Most biomarkers are known. The effectiveness is already known of the biomarkers. There's really no reason to duplicate that work. And so what I would say is that ultimately when they allowed manufacturers to come on the market through the EUA process, where they were submitting data that is essentially an analytical validation, basically describing the test performance characteristics, that actually is a much better, in my view, model than to require extensive clinical studies, because most markers would be more analogous to or most tests would be more analogous to the situation with COVID-19, where we understand the marker we're detecting. We just need to know the clinical performance characteristics of the test. And as a person who purchases those tests and uses those tests, in addition to setting up our own, it's created a dynamic that has resulted in over-regulation of commercially manufactured tests, which has created a tension and a dynamic where actually companies have been encouraged to engage in economic rent-seeking in order to try to over-regulate laboratory-developed tests, which they view as competition.
Great, thank you.
I would only add to that, Greg, that the LDTs, the laboratory developed tests, are usually being pursued by companies, by laboratories that have an unmet need. So they have a need for a rare disease, or for some reason the machines they have will not run the particular test. So they seek to develop their own test. And these are not fly-by-nights. These are not two guys in a garage cooking up a test and trying to apply it. It's usually well-established, highly respected academic laboratories, like the University of Washington had developed a test. Stanford was developing its test. My institution developed a test for Mount Sinai in New York City developed a test for antibodies. These are well-established, well-known CLIA certified labs. Remember I said CLIA has a level of complexity. Most of these are high, they've been certified to do high complexity testing. So they are, you know, well-established labs. There's very little concern, or there should be very little concern about them doing something that cannot be validated.
Great. So Joel, we're now, what, 5 months, almost 6 months into the outbreak. At this point, the Food and Drug Administration has now issued literally dozens of emergency use authorizations for both laboratory developed tests and for commercial test kits. What more do we need to do now to make sure that doctors get what they need in terms of testing?
Well, I think that the first and obvious thing is to get rid of the counterproductive regulations and make some of the regulatory relaxations that have finally occurred in the last few months, make them permanent. So the first thing I think we have to consider is reconsidering the LDT process and making the long-standing FDA practice of enforcement discretion, making that a permanent feature of the regulatory scheme for laboratories that we have some assurance are reliable laboratories, you know, like, as I said, the CLIA high complexity laboratories, laboratories of major medical centers. It could even be laboratories that are overseas that we have reason to know or think have high reliability, and allow so that when you have another emerging infectious disease outbreak, you don't have what happened here. You have the ability for innovative new laboratory tests to come on board quickly and fill the testing capacity void. The second thing is I would regularize the EUA process so that it's transparent to all the parties involved, and that it encourages innovation, so you can spur the availability of these new tests very quickly. So you want to require, so for example, in this instance, what happened was there was no EUA guidance issued until the end of February. There should be a requirement that FDA, once an emergency is declared, that FDA issue EUA guidance quickly, say within a matter of weeks, rather than waiting for an entire month. You should open up the EUA process so that innovative companies and labs can participate, and we can avoid this fiasco of just having a single EUA issued for the entire month of February for diagnostic tests. I think you should also mandate that the FDA will issue EUAs for all qualified labs, whether here or abroad, unless FDA can show some sort of reason not to. So the onus will shift to them as long as the laboratories involved have demonstrated a certain level of reliability and capacity. And that includes, by the way, these CLIA exempt labs that I referred to before, where the states have made. So you have, for example, in New York State and in Washington State, you have well-established public health labs which are capable of making these tests, and they've been exempted from the process, but they were unable to participate here. And I would even throw out that we already have a program for what's called mutual recognition that the FDA does with foreign governments for inspection of production facilities for good manufacturing practices. So in other words, we will take Germany's word for it that their inspectors have come and inspected the production plant in Germany. We don't have to send FDA inspectors. We should maybe be thinking about some sort of mutual recognition for these development of diagnostic tests, just so that we can take advantage of the fact that the German companies and the German Research Institute were ahead of us.
Great, thank you. Now, Roger, you're a veteran of these debates. Tell us a little bit about the reform proposal that you helped develop with the Association of Molecular Pathology, and this goes back well before the current crisis.
Yes, so this gets back to the dichotomy in regulation, and again, as Joel suggested, clinical laboratories are regulated under the Clinical Laboratory Improvement Amendments and the subsequent regulations, and those regulations were initially released in in 1992, and have had some modification, but not a full level of updating to comply with or to meet contemporary laboratory conditions. What the way that the reason that they function so well is largely because we have a system of third-party reviewers, third-party accreditors that are with expertise in the field that largely manages for the complex labs the accreditation, in addition to states like New York. So the College of American Pathologists, which is the largest accreditor, it accredits over 7,500 labs, has 1,500 pages of checklist questions. There are the CLIA regulations themselves are sort of are broadly written and somewhat less prescriptive, and obviously, and as anybody familiar with the regulatory process understands, not updated regularly. So what we proposed was to at the Association for Molecular Pathology was really a CLIA-centric model where we would modernize the CLIA regulations to somewhat account for developments in newer technologies such as next generation sequencing and gene expression profiling that would provide a somewhat higher level of guidance for laboratories through the regulatory process. Now, I would, as I suggested, most of this for the complex labs is typically handled through experts with professional societies or other deeming entities that deem labs compliant with CLIA. The other thing I would mention is there is a legislative proposal called the VITAL Act. I can't remember the exact acronym right now, but put forth by Senator Rand Paul, who himself was affected with COVID-19, which clarifies that CMS is responsible for regulating laboratories and the tests developed within for use by our own patients, and that FDA is responsible for regulating tests that are manufactured, shipped, and distributed throughout the country. So that's basically the idea is to work through the CLIA model that for which there's no evidence, by the way, that there's any systemic problems with laboratory testing in the United States. I've been in labs where pretty much every single test was laboratory developed. If you buy an FDA test and you don't exactly follow the label, it becomes it becomes a laboratory developed test, and you have to modify it. So there's so much complexity in this. But if you take the labels are often very prescriptive, and if you use general purpose instruments or reagents that don't match the label, you have to validate it as if it is a laboratory developed test anyway. So I think that the proposals that we're putting forth fit with the existing evidence, which doesn't support the need for FDA intervention, and in fact, arguably in this case, but there are many others, does harm. So that would, and what I would urge, in fact, is a lessening of the burden on companies to give laboratories greater choices in the tests which they could purchase and say, I would rather, as a laboratory person, I would rather buy something than have to regenerate it myself. But if the FDA makes it too costly and risky for companies to put tests on the market, they're not going to do it, or they'll sell them as unapproved products, or they'll sell them in Europe, and then we'll buy them in Europe and we'll validate them as laboratory developed tests. It's a complex area, but I think what we're seeing is an over-regulation of FDA in the commercial sector, which is causing a lot of harm, and it adversely impacts the laboratory sector as well, and forces us to develop more tests on our own. There were almost no molecular genetic tests, non-infectious disease, that had FDA clearance or approval for many years. And I think, as Joel said, we're talking about unmet needs, but part of that is the problem, and the reason for that is because of FDA And so FDA is not helping here, they're harming.
Thank you, Roger. So I'd like to take an opportunity to remind you in the audience that if you like, you can submit a question at any time using the Q&A box at the bottom of your screen, or by sending a question to events@cei.org. Let me turn to Joel for a second. Joel, we've been talking about the distinction between laboratory developed tests and commercially available test kits. But there's also a distinction to be drawn over what the tests are testing for, whether it's the live virus or antibodies. Could you walk us through that distinction and tell us why it matters?
So it's an important distinction that many people don't understand. So the tests that we started out with, where I was talking about the delay, were the tests for the virus. And there you're testing for the actual the virus itself, and it's done through polymerase chain reaction, a well-established procedure. And what it indicates is that you currently have virus circulating in your body. So these are the tests where you see people getting nasal swabs or oral pharyngeal swabs, and that's what you're testing for. You have a current infection. The second kind of tests that you refer to are what are called serology tests, and there you're testing for the presence of antibodies. And what antibodies are proteins that your body generates in reaction to having had an infection. So it doesn't necessarily indicate that you have a current infection, but it often indicates that you had an infection in the past. And that's most of the time what we're seeing, because it takes a little bit of time for those antibodies to rise. There are two main types. It's not important to get into that, but for most people, by the time you're seeing them have the positive antibodies, they've probably already recovered from the active infection. So the serology tests are not being done to show to test for current disease. They're being used to test for your exposure to the disease. And that's important for two reasons. Number one, if this virus behaves like most do, and there's no reason to think it doesn't, you will generate antibodies, and that confers some degree of immunity for some period of time. And that so far it seems to be that this virus is behaving the exact same way. So you know it's now safe for you to go out. You're not in danger. And more importantly, it means you're not going to get infected again. And as long as we know you don't have an active infection, we know you're not going to endanger anyone else by coming into contact with them. And the peculiar thing, after I sketched out that chronology about the virus testing at the front, was that the FDA did the exact opposite in a very peculiar way for the serology testing. So in the middle of March, they announced that manufacturers could distribute serology tests as long as they notify the FDA about it, but they don't need to apply for an EUA. So the market was flooded with hundreds of different serology tests, and many of them were faulty, either outright frauds or just unreliable. Many of them happened to have come from China. And it became obvious over the succeeding weeks that this was a real problem. So the FDA ended up revising the guidance, really, I think about a month or two later, and they said they would now allow commercial manufacturers to distribute the serology tests for a limited time while they prepare an EUA, very much like the other testing. CLIA certified high complexity labs would be allowed to develop serology tests without an EUA, which is our standard LDT process. And they had there was ultimately a memorandum on expanding state-approved diagnostic tests. Again, sort of the CLIA exempt lab. So they finally got around to sort of a reasonable regulatory scheme, but it took them months of having done virtually nothing and encouraged faulty tests to come onto the market.
I think. So Roger, Joel raises an interesting point. I mean, there does in fact seem to have been, after the Food and Drug Administration started granting these blanket authorizations for serology tests, there does seem to have been a number of faulty tests that came into the market, and regulatory reform skeptics would say, well, that's exactly the reason why we can't do the things that you and Joel have proposed to lighten the footprint of regulation. How would you respond to that?
Yeah, so I think it's a different issue. These weren't authorizations, by the way. FDA basically said that anybody can register and offer the test. So they weren't authorized. They weren't EUA tests. There were manufacturers, legitimate manufacturers, the common test manufacturers we use that got EUAs. But as suggested, there was a dump of a lot of tests of probably low quality trying to be sold in the United States. Whether anyone bought them or not, it's unclear. Certainly laboratories are obligated to validate them, and any competent laboratory would recognize that these tests weren't performing properly in their validation. But I think it brings up an important issue, because first of all, it's analogous to the protective equipment. There were over 1,300 manufacturers from China that registered with FDA for PPE. And they were all from the same non-existent address with a non-existent phone number, and FDA never picked it up. And similarly, when FDA, and look, I have lots of friends at FDA, I'm not meaning to be critical, but FDA said, well, we recognize that, first they said, the role of serology was not really a diagnostic role. It didn't really have a role yet. So that was one of the reasons they were less concerned. But the other thing is, they said we recognize they're less complex than PCR. Well, this is not actually true in today's world. A PCR reaction you can set up with a high level of sensitivity and specificity and understand it, whereas a serology test, you have to ensure that there's no cross-reactivity with other viruses, like other coronaviruses that circulate all throughout the country. So they were wrong on that count as well. But I think what happened was similar to the PPE. You just had this flood of tests. I very seriously doubt if people were harmed by their use. We really don't have a role other than surveillance. Serology tests haven't really haven't achieved a widespread role in clinical testing, because the extent to which immunity, for example, is conferred by antibody. Obviously, there's some, because you got over the disease, and there's certainly going to be immunologic memory, but we really don't know how immune you get. So we don't understand fully the role of serology. You can supplement a diagnostic test if you're in a window where the diagnostic test is going to be less likely, but by and large, their clinical role hasn't really been worked out. So the harms and that's what we're looking at. We're looking at benefits versus harms. Even from this flood of really bad tests, the harms that were likely to have been done are probably non-existent. I haven't heard of any harms from these tests. I don't know anybody who's used any. I have asked around, but there could be fly-by-night labs that set up to buy these types of tests, but an experienced laboratorian who's trained, we have highly trained professionals doing this work, pathologists and doctoral scientists who are experienced in laboratory technologies, techniques, and medicine. And we go and we evaluate things, and we validate the tests. And so again, you would pick it up if you buy a low quality or poorly performing test. You're going to see it, and in fact, we see it with FDA cleared and approved tests that have gone through the full process.
Great.
Greg, I would add one thing to two things really. What Roger said is, I think there was a report that FEMA, in fact, had bought thousands of faulty tests from China and ended up having to discard them.
In fact, I think it was worse than that. Is that FEMA contracted with a large number of U.S. manufacturers that had never before even been in the medical device or diagnostic manufacturing space. So these were in fact those kind of two guys in a garage that you talked about earlier.
Right.
The federal agency charged with overseeing emergency management was making these poor decisions, not well-run clinical laboratories.
But there's one other thing that I think Roger's comments highlight is our dependence for the drug and medical device and equipment supply chain runs very heavily through China. And that's what this COVID pandemic has highlighted, that most of our PPE is manufactured overseas. And for drugs, a huge percentage of our drugs are manufactured overseas, particularly generics. And even when the generics appear to be manufactured in India or manufactured here, in fact, the active pharmaceutical ingredients, the chemicals that go into making them up, are actually manufactured in China. So about 80% or more. So it's highlighted our dependency on China, a dependency which obviously can be exploited in times of international tension, and a dependency which may be unhealthy if we have doubts about the reliability of the quality of those products.
Let me shift gears a little bit before we get into audience questions. Joel, you've done a lot of writing about the role that testing, particularly serology testing, is likely to play in reopening the economy, reopening schools, reopening other social activities. A number of big companies have announced that they intend to fund testing for their own employees, and others are moving into the space. You know, what does the next 6 to 8 months look like in terms of increasing the amount of testing and using those tests to regain a sense of understanding of who's susceptible, who's not susceptible, et cetera?
Well, I think the first goal of testing, and this is for the virus, is to mitigate the spread of disease. So you identify who's infected, you isolate them. If possible, you undertake contact tracing and find out who's been exposed to them and see whether they've been infected, or at least have them quarantined so they can't transmit the disease. So you want to interrupt that transmission chain. And the second thing, though, is I think that testing is going to be very important to reopening the economy. Businesses have a very strong incentive to to make sure that their businesses are safe, both for their employees and for their patrons. So one thing they can do is they want to make sure that they don't have an infected person on the premises who's then going to infect all of their other employees. And then you have a lot of absenteeism because a lot of people are sick. They want to identify the people and make sure they don't come to work. They want to isolate them and make sure they're not available at work. They also want to reassure their workers that there's a safe working environment, because it's clear that a lot of people fear going into work because they fear getting infected. So that's another source of absenteeism that they want to nip in the bud. So they have a tremendous incentive. They also have an incentive towards, if it's a retail establishment, for example, to reassure their patrons that it's safe to come in and patronize the place. So they want to be able to advertise that we've tested. So for example, when I go into stores now, I see signs that say we sanitize, and they give the name of a company, which I assume is legitimate. But imagine if testing was readily available, they could say all of our workers have been tested, they're all negative, or all of our workers have antibodies, so you needn't fear that you're going to be infected. So I think it's key to getting the economy back open.
Roger, with all these private incentives, whether it's businesses or other establishments, or even individuals have incentive, obviously, to learn about their health status. I mean, is there any reason why government needs to be involved in providing the testing?
I don't think government should do the test, and I don't, I'm not convinced that government should play a role in allocating the resources to do the test. I think it's probably causing more problems than it's helping. Look, so I have a different perspective. I agree with Joel that some businesses it's going to be very important to test. And I think particularly, for example, in a nursing home where 50% of the deaths have occurred, we need to put hospital-like protections in there, and we need to test regularly in order to pick up outbreaks quickly. But in my view, there was a paper published in the Proceedings of the National Academy of Sciences a week or two ago, and it suggested that we would need to identify and isolate over 1/3 of asymptomatic infections and all symptomatic infections in order to suppress the virus to less than 1% of the population. Now, it's a model, and it may or may not be right, but I think fundamentally you're looking at a disease that is probably twice as contagious or potentially twice as contagious as the flu, with a longer window of mild or asymptomatic infection during which time a person can spread the disease. And I think we need to be realistic and understand that there are lots, millions of infections. The infection fatality rate we now know is very low. It's, in the order probably of 0.1 to 0.4%. And if you're under 70, it's much lower than that. And I think what we're going to need to do is kind of medicalize it, use testing selectively in settings in which it's going to make a difference. Joel is completely right. I mean, you don't want to have your whole workforce out, and some people will be very seriously affected by this who are not old and sick. It's just that, that tends to be the people who get hospitalized and die from it. But I think we need to be realistic and try to focus our efforts, and I think the private sector is probably going to be more effective in doing that than the public sector is. We have a situation right now where the entire world is dealing with an epidemic, and we've got worldwide demand for the reagents and the testing. We've tested millions and millions of people. We're doing about 700,000 tests a day. Nobody can test everybody here. And if you test somebody one week, and they're negative, they might turn out to be positive the following week. So I think we're going to need to medicalize this from the clinical standpoint, from the infection standpoint, and I think we need to look at certain settings where testing can benefit functions. I think businesses are probably going to be effective at determining for themselves when that could be. We may need to have some encouragement or stimulus to do it in settings where there are high-risk populations like nursing homes, but I think we need to start being realistic about what's got to happen, which is enough people have to become immune either through infection or which is probably going to happen sooner than or a vaccine for this epidemic to burn out.
So let me turn to some of the audience questions, and I'm going to paraphrase this for brevity, and I'll ask either or both of you gentlemen to chime in on this. What is the role for herd immunity? For those who don't understand it, briefly explain what herd immunity is, and how do we make sure that we know that we're working toward herd immunity either through exposure to the virus and people showing antibodies, or down the road a vaccine.
So herd immunity, for your viewers, you have to understand the way the infections of these infectious diseases usually go. And there's what's called a pandemic curve. It's kind of like a bell-shaped curve. And in the early days, when there are a lot of people who are susceptible to infection because they've never seen the virus before, a lot of them get infected. So you're on the steep ascending part of the curve. You reach a peak and then you start to decline when enough people have acquired immunity so that every person who is infected is now infecting fewer people, because some of the people they encounter are now immune, so they don't infect everyone they meet. And the way, as Roger said, the way you get immunity is either through a vaccine or through you're having been exposed. And when enough people have been exposed so that you can adequately interrupt that transmission chain and be on the downside of the curve, that's when you've reached herd immunity. And no one is 100% sure of what the magic number or numbers are for herd immunity in this disease. It's thought probably to be somewhere between, say, 30 to 60%. A lot depends on the setting. It depends on what other measures you're taking, in other words, how much people are exposed, what they're doing to interrupt exposure. It depends on what stage of the pandemic you're at. Usually what's called the R0, the number of people that one person will infect, is much higher at the outset. It's much lower towards the end of the pandemic. So we don't know. I mean, and no one really knows exactly how many people have been exposed, because you can't test everybody. And even with the serology testing, we haven't done wide enough testing. The best knowledge we have, I think, to some extent, comes from New York City, which was the epicenter of the outbreak here, where serology testing that was done showed that in New York City, probably about 22% of the population had been exposed. And it's probably higher now. That was done probably a month or two back. But that's in a setting where you had very high prevalence. If you go to the middle of Montana, it's probably 1 or 2%.
Another question I'm going to direct to Roger in the interest of time. We're running short. Question is, we're now hearing reports that the test results are being delayed by a shortage of laboratories capable of processing these tests. How big a problem is this, and what will it take to resolve it?
Yeah, so I just did an informal survey of several labs. I think many labs right now are at capacity. There's been a problem with the ability to acquire reagents and other things like that have slowed things down. And then we've had this recent ramp up. So labs expanded their capacity, and then they had excess capacity. And this has gone on for weeks, despite what we were hearing in the media. People I talked to, nobody was at capacity. But then all of a sudden, we've had this explosion in cases, and so even the largest commercial laboratories, which are doing thousands and some maybe 100,000 tests a day, are still, at least for some, are still at capacity. And they also have contracts, by the way. So you have built-in testing with companies that have, or institutions, entities that have contracted with these laboratories and have reserved space to do the testing. But I think that it's less probably an absence of labs. People will expand their capacity, especially the commercial laboratories have an ability to expand their capacity, although it isn't indefinite if you can't get your hands on instruments and reagents. But I think that problem will be solved in the sense of having capacity to do it. It's just, you can't test 330 million people, and that's sort of if that's what we're looking at, I think we're going to be disappointed. We're competing with the entire world for reagents and instruments to test. So again, I think the issue is labs tend to be pushing their capacities right now, although certainly not all that I talk to. But I think what we need to look at is being selective and judicious. And I'm not saying, and I'm not necessarily saying that we're talking about testing only the sickest patients, as we did in the beginning, which gave us a completely skewed perspective of the disease, and in some ways, from a public health or epidemiologic standpoint, was harmful by providing people with information that was somewhat misused. But I think using testing selectively in settings where it's going to derive the most good, whether that be in employment settings for economic purposes, whether it be in nursing homes to protect very vulnerable populations. I think we need to make these decisions carefully and wisely. And of course, people are free to do their own. We have states, and we have, they're providing testing for free. Sometimes what we're talking about when people say they can't get testing is they mean they can't get free testing. You can get the testing. You can get testing. You can send it to LabCorp. You can send tests to laboratories that might not come back immediately. The hospitals are having shorter turnaround time, so you can get that information back quickly or more quickly. But I think you might have to pay something. And that's also part of what we're talking about.
So Roger, you said if you want a test, you can get a test. I think the other hurdle is getting a doctor to write a prescription for a test. There have been proposals to allow pharmacists to order tests, including COVID tests. What do the two of you think of those sorts of proposals?
I mean, I'm fine. I don't, I actually don't. Some states allow people to order their own tests. I don't have a problem. I have less problem with that than some people. It's kind of paternalistic to tell people they can't order a test and have right to their health information because you need to protect them from getting from misusing the information, so they have to go pay to see a doctor or something. So yeah, I mean, I think that's okay, but I don't. I think it's fine to broaden the availability of people's decision making in their personal health decisions.
Right.
I would echo that. I don't have a particular problem. I do think, though, that one thing that has, as a result of that early shortage of tests, as Roger said, we were only testing the sickest people, and that skewed people's impressions of what we were dealing with. The fact that you only tested people who were sick, very often with severe symptoms, meant that people thought this was a death sentence, when in fact it became clear relatively early on that there's a high rate of asymptomatic infection. Probably about half the people who are infected have no symptoms, and most of the people who have symptoms are very mild. So in fact, the infection fatality rate's quite low, but people, because of the early shortage of tests, think the infection fatality rate is sky high. They think it's like Ebola, and this is not Ebola. But as a result, people are now scared stiff, and they all want to get tests, when for many of those people, there's absolutely no reason for them to get tested, particularly if they've been assiduous in their sort of adherence to things like social distancing and mask wearing and things like that.
Great. So we've unfortunately are running low on time. There are lots of great questions, but I've got a stumper for you that I'll make the last question I'll ask, and hopefully both of you can chime in on this one. To the extent that businesses start using serology tests to identify either employees or customers who are immune, what thought do we need to give to possible protections against discriminating against people who are not immune because they've not yet been exposed or haven't had access to a vaccine yet?
Again, I
Please go ahead.
And just quickly. So first of all, the problem with doing serology tests where there's a low prevalence of positivity is, even with a really good test, you're going to find more false positives than you will find true positives. So that's a consideration that, from a Bayesian statistics point of view, that people need to be aware of. But in terms of discrimination, I think it's a concern, and I also don't think this disease is serious enough to warrant measures, for example, to exclude people from working who choose to work. I think you can exclude people who can infect others, but those who want to take the risk of infecting themselves, I don't personally believe it's justifiable to exclude people who choose to work and need to make a living because they haven't been infected.
Joel?
I think, Greg, you were asking though about the reverse, that if someone can't demonstrate that they've been exposed, that they're still vulnerable, they're still susceptible to infection, excluding them. And I can't imagine the scenario where that would happen, so that the discrimination concern is, I think, really, in that case, a bit of a straw manning, unless you're talking about, say, particularly vulnerable populations, like you wanted to exclude octogenarians who have a negative serology test from coming into your restaurant. But even there, there are things you can do, there are accommodations you can make that would make it much safer for them to come in. So I think it's highly unlikely there'd be much discrimination on the basis of serology testing.
Great. All right, unfortunately, that question alone could have opened up another 20 minutes worth of conversation. But we are, I regret to say, out of time. So let me thank both Roger and Joel for joining us and sharing their thoughts with us today. I want to thank the audience members for participating in the program today. When you log off Zoom, I'm told you'll get a pop-up survey asking about the today's program, and I would ask you if you would so kindly fill out the responses to just a couple of questions. Tell us how we've done. And finally, before I log off, I'll invite you all to join us next week on Thursday, July 23rd, for a book forum with environmental scholar Bjorn Lomborg discussing his latest book, False Alarm, which I believe, if I'm not mistaken, was just published yesterday. So with that, again, thank you, Roger. Thank you, Joel. Thank you all for joining us. And please have a good day.